Hi everyone, welcome to the module on bioethical considerations for navigating the translational and commercialization pathway for neuromedical devices. This topic is called Bioethical Considerations Beyond the IRB. My name is Anna Wexler, and I'm an assistant professor in the Department of Medical Ethics and Health Policy at the University of Pennsylvania's Perelman School of Medicine. My research focuses on the ethical, legal, and social implications of emerging neurotechnology, and much of my work has centered on ethical issues that arise when neurotechnology is used in ways that were not initially intended by researchers or developers. I've also done research on ethical issues and novel methods of neuroscience research, such as intraoperative intracranial studies where there's no expected benefit to the participant. The objective of this lecture is to become familiar with bioethical issues that arise outside of traditional research, ethics training, and oversight. So outside of those issues that you may have learned about in responsible conduct of research or RCR training, and outside of topics that may arise in institutional review board or IRB oversight. The ethical issues that are covered in typical RCR training that many, if not all of you, have already probably completed include things like authorship, data management, conflicts of interest, and how to ethically conduct research involving human subjects. These are all very relevant topics to translational neural devices, and there are many excellent resources, including online modules, that can provide an initial overview or even a refresher. And I've provided links to some of these resources at the end of the slides. But the point of this lecture is to discuss some of the ethical issues that you won't necessarily learn about from those sources. So why is this important? Why is there a need for this? Well, RCR training and IRB review may not encompass issues that are really at the cutting edge of neural device research, right? Which is presumably where you are. So it often takes time for certain ethical considerations to emerge and for methods to be developed to address those issues. And the work that ethicists are doing now to identify and study some of these issues could take many years to become part of official considerations. Still, though, the NIH and other funding bodies are really increasingly recognizing the importance of considering these emerging ethical issues. And some NIH Brain Initiative grants are actually now requiring that applicants include a section on what's called neuroethics, which just refers to some of the specific ethical issues that may arise in the neuroscience context. So this is an indication that the NIH is quite serious about considering ethics at an early stage and is very serious about considering ethical issues that fall outside the types of things that are typically considered in research training or compliance. So what I hope is that this lecture helps you better reflect upon these ethical issues and also helps to guide you in thinking about what funding bodies like the NIH are looking for in those neuroethics sections. So in this lecture, we're going to focus on 3 emerging ethical topics related to neural device research and development that are increasingly being recognized as important, but for which there's really little consensus or guidance at the moment. And so the first area that we're going to touch upon today is informed consent. And I know I just mentioned that I would not be covering areas of research ethics that are already covered by RCR training and IRB oversight, but there are some unique issues with regard to informed consent in the neural device space. And we're going to talk about 3. There'll be setting of the informed consent, capacity of the participant to consent, and what to disclose to a potential research participant. After that, we'll cover post-trial responsibilities, and here there's really a lack of agreed-upon standards regarding who's responsible for what, who should bear certain financial costs, and how long obligations should last for. And I'll talk about some of the issues that arose in a trial that was conducted several years ago. Finally, we'll cover considerations of unintended consequences, which occur when a product or even information that results from a research study is used in ways that were not originally intended by the researcher or developer. And here I'm going to provide an example from the do-it-yourself brain stimulation movement and also discuss ways that you can work to better anticipate unintended consequences. So, kicking things off with informed consent. So, I know on its surface it may not sound like the most interesting of issues, but again, with regard to neural device research, there are really interesting questions being raised here. And one of these in particular is with regard to setting. So, who does the consent, where and when it should be obtained? There's just really no consensus here, and practices vary widely. So in terms of who should obtain consent, a clinician like a neurosurgeon may be best suited to discuss risks, but if he or she is also the investigator, the dual role here raises concerns about participant voluntariness, or how voluntary the participant's consent is. So for example, participants may feel obligated to say yes, right? Especially in the context of, say, an upcoming surgery that their neurosurgeon is scheduled to perform. Relatedly, where research and clinical procedures are closely linked, so one example is the implantation of a standard of care device with new software or new stimulation parameters, it's important to avoid the therapeutic misconception, which is when a participant believes that a research study will provide them with a therapeutic benefit. And that's an erroneous belief, right? So there's a misconception on the part of the participant that the research is actually therapeutic in some way. And so here it's really important to be as clear as possible and to think about setting as much as possible to prevent any kind of therapeutic misconception, or at least attempt to do that. This leads to the next point, which is about when and where consent should be obtained. And here there's trade-offs between convenience and ensuring that participants are not too overwhelmed to comprehend study information. So for example, if the informed consent is conducted during a pre-surgical visit, or perhaps after a long and taxing day of undergoing lab tests, but where the participant is conveniently, in the laboratory or in the clinical setting, participants might not be in the right headspace to fully comprehend what a research study entails. The next issue with regard to informed consent that we'll discuss is capacity, and this raises really interesting questions because neural device research is often conducted with populations who may have impaired decisional capacity, such as patients with neurodegenerative diseases. And again, here there are no standards, there aren't any hard and fast rules, but if you are concerned about participants' decision-making capacity, there are validated tools that exist, such as the MacArthur Competence Assessment Tools for Clinical Research. For short, it's called the MCAT-CR, that can assess the capacity of a participant to consent to research. And I've linked to this tool at the end of the slides. The last aspect of informed consent that we'll touch upon is disclosure. So it's typically disclosed during the informed consent process are physical safety risks. And risk here is usually defined as the probability of occurrence of an adverse event. But there's starting to be a recognition that there are risks beyond safety risks, right? So risk beyond the probability of an adverse event that might need to be disclosed. So Hendricks et al. Have called these atypical risks. And in their paper, which I really highly recommend looking at, they give examples of things like personality change following implantation of a deep brain stimulator, financial risks due to required costs of device maintenance, and security risks due to concerns about hacking. So it's also important to pay attention to what they call emerging risks, where there might be some early data indicating a potential risk, but the evidence is still unclear, or the probability of occurrence may be unknown. It's really difficult to know what to disclose, but certainly for atypical risks that are either established or very probable, always best to err on the side of disclosure. And again, I really encourage you to check out the Hendricks et al. Paper, which has a really nice section on this, and I've linked to it at the end of the slides. Finally, and as we'll talk more about in the next section, it's important to disclose post-trial responsibilities and long-term scenarios. So the informed consent process is often really laser-focused on the immediate study itself, and the participant and even the investigator, right, may not be thinking about what could happen down the line, 5, 10, even 20 years into the future. But it's the responsibility of the investigator to consider post-trial issues, especially for implanted neural devices, and really disclose as much as possible. So the main takeaway from this section is that in the absence of formal guidance, it's important to carefully reflect on issues regarding setting, capacity, and disclosure with regard to informed consent, and to consider the most ethical way that you could navigate forward given the constraints of your particular study. Okay, the next main topic we're going to cover is post-trial responsibilities. And here too, there are no existing frameworks or agreed upon standards. Considerations of post-trial responsibilities are relevant to all neural device research, but they're especially important when it comes to invasive devices, where it's really crucial to think not only about the study itself, right, but also what can happen down the line. And there are many open questions here, including which stakeholders are responsible and for what, who should bear financial costs, and what the duration of the obligation is to research participants. One example or case study that helps illustrate some of these issues is the Broaden trial, which was conducted about a decade ago. This was a trial that was sponsored by St. Jude Medical, and its purpose was to investigate whether deep brain stimulation was effective for treatment-resistant depression. And after an interim analysis did not show particularly great results, this was done at about the 6-month mark on about 90 patients, St. Jude, not the FDA, decided to stop the trial. The thing was, and this is something that became apparent at a later stage, that some participants actually really hugely benefited from having the device. And so this situation brought up a number of questions, right? So first, what happens when a trial fails, but the patient benefits, right? Who's responsible for follow-up and for maintenance? What if the patient asks you to replace the battery after the trial has ended? And what if they tell you that this is the most life-changing therapy that they've ever had, and they can't imagine going on living without this device? These are some of the questions and issues that emerge from the Broaden trial. Another issue that came up is what happens when a research subject has atypical complications. So maybe there's a plan for who's going to cover the immediate costs, right, associated with complications related to surgery. But what if a participant experiences atypical complications that are maybe related to the implantation, but the situation, is not very clear? So one participant in the Broaden trial ended up footing 6-figure medical bills and actually becoming embroiled in a long legal battle, and this has been reported in the media, because he experienced a kind of scarring after implantation. And the investigators, according to him, told him it wasn't common, and he had a hard time finding a physician who was willing to treat him because he was a participant in a study. So things can get really complicated, and questions can arise around who is fitting the bill and for what, right? These situations are not always clear-cut. So here are some of the main points that you might want to consider with regard to post-trial responsibilities. First, who will be responsible for maintenance for things like battery replacement, device repair, treatment of infection? Who's responsible for these things during the trial, and who's responsible for them when the trial concludes? Second, post-trial access. So will the participant have access to the device after the trial ends? What happens when some participants benefit, but the trial itself fails, right? Like in the Broaden trial. Third, device removal. This is an important one because participants may not understand that explantation can be even riskier than implantation, and that in some cases explantation might not even be possible, right? And again, as illustrated by the Broaden trial, what if they experience health complications that may be loosely tied to the research, right? Who covers those costs? And finally, there is an impact on routine care. This is just one example, right? But having a deep brain stimulator impedes participants' abilities to get certain MRIs, right? So what if they end up incurring extra expenses because their insurance won't cover them for the special procedures they need because they have an implanted investigational device? So this is certainly not an all-inclusive list, but I think this covers some of the main issues that have arisen in this space. So how can you navigate some of these issues? Well, first, it's important to anticipate the issues themselves and their potential costs by considering multiple scenarios. One way of doing this is by thinking through the different kinds of issues that have arisen over the years, such as those that occurred, for example, in the Broaden trial. Second, plan accordingly. So include costs in your research budget, delineate responsibilities across time. Think about which issues are the responsibilities of the sponsor, the investigator, and the research participant, and how long those issues last for. And finally, as we covered earlier, it's important to disclose these post-trial scenarios to research participants during the informed consent process. So this is certainly not easy territory to navigate, but I'd say that the takeaway from this section is that it's crucial to do these three things, right? Anticipate multiple scenarios, plan accordingly, and disclose responsibilities to research participants. These are things that the NIH will definitely want to see you discuss in any section on neuroethical considerations. Okay, moving to our final topic, which is unintended consequences. These are unexpected effects, typically negative ones, that occur when a product or sometimes even information is used in ways that were not originally intended by the researcher or developer. And what I mean by that is that when researchers and developers typically think about a product, they usually have a kind of assumed trajectory in mind, right? That the product or device will move from the research space to trials, to approval, to the clinical domain. That's just one example of a kind of trajectory that's imagined. But that trajectory can get disrupted. And to illustrate how that can happen, I'm going to give you an example from the case of transcranial direct current stimulation, or TDCS, and the emergence of a do-it-yourself brain stimulation movement. So TDCS is a non-invasive electrical brain stimulation technique that gained traction about 10-15 years ago, when lots of studies came out claiming that it had promising effects for indications like depression and chronic pain, and also that it had cognitive enhancement effects in healthy populations. The technique began to draw a lot of media coverage, and what happened was that in late 2012, people who were not scientists began reading about it. And because these devices were actually quite easy to make at home, essentially you just needed a 9-volt battery and some electrical know-how, people began to create these devices on their own, stimulate their own brains, and post what they were doing to YouTube. And they also began to read scientific papers themselves and really delve into what scientists were publishing. And then they took that knowledge and used it to stimulate their brains, which is clearly not what the scientists studying TDCS had intended. And this movement became known as do-it-yourself brain stimulation, or DIY brain stimulation. And it was a very interesting phenomenon because on the one hand, you had scientists researching the device and using the technique, using IRB approved protocols, administering stimulation in very measured and constrained fashion on research participants. And then you have this parallel movement of lay individuals, of people at home, doing this in their garages and basements with no restrictions and stimulating far more frequently than scientists were doing. And this caused a lot of controversy. So scientists spoke out publicly against the DIY movement, and the FDA and some major professional organizations held meetings about what to do about this DIY movement. And I'll say it hasn't been really resolved, but I think that scientists really have just learned to live with this parallel world of home brain stimulation. And I should also note that TDCS has not ever received FDA approval or clearance, though I'm not sure that's due to the DIY movement. So what happened here? Well, neuromodulation researchers had imagined limited use cases and users and were really surprised by unintended uses, right? So they had this typical trajectory in mind, the one I mentioned earlier, and then things went in an unexpected direction. And there was a broader context surrounding the technology that they did not envision, and arguably they could not really have envisioned. So there was really a perfect storm for the creation of a DIY movement, right? So there were frustrated patients who were trying TDCS because, say, all the drugs they tried for depression didn't work. There was a growing interest in productivity hacking and brain optimization, which motivated those who used TDCS for enhancement. There was an increased capability for scientific information to be shared online. So users could share the latest experiments and scientific protocols. And there was also the ease of replicating this technology at home, right? So users could create their own devices. So all these broader contextual factors really set the scene for the emergence of this DIY brain stimulation movement. So I can't argue that researchers should have envisioned these things, but at the same time, it's a good illustration of how there can be unintended or unexpected uses of a product that are hard to envision. So rather than throwing up our hands and saying, there's nothing we can do, there's no way we could have envisioned that, another more constructive approach is to say, well, what can we do in the future to anticipate unintended consequences? And while it's true that consequences can never be fully anticipated, there are some tools that can help us identify potential harms. Many of these tools come out of the literature on what's called responsible innovation, which developed in the European context, but has more recently been adopted by tech companies and others here in the US. And the idea behind responsible innovation is that rather than waiting until a technology has been developed to think about downstream implications, we can start to think about potential implications now. And there are various responsible innovation toolkits that can help you think through implications, and I've included links to some of them at the end of my slides. But I just wanted to share a screenshot here of the one that Microsoft uses and one that they've publicly posted related to harms modeling. And this involves, their approach anyway, involves defining the purpose of the product, describing different use cases, and here you can think about unintended use cases, right? Considering different stakeholders, assessing the potential for harm, and then building or planning for positive outcomes. And where this approach is different from traditional FDA risk assessment is that it encompasses harms and risks outside of pure safety consideration. So it also pushes developers and researchers, right, to think about unintended consequences, or what might happen if the technology is used in different ways by different users outside of the standard imagined trajectory. So there are many responsible innovation toolkits and frameworks, but the general approach is really outlined here. So the first step is to proactively anticipate. And here responsible innovation exercises, like the harms modeling one I shared on the previous slide, can help identify potential downstream harms. And it's important to include diverse stakeholders in these exercises because researchers and engineers designing a product for a specific neurological condition may not fully understand how the device could be utilized in practice. Second, reflect and implement, just like in the post-trials responsibility section, but here it's about incorporating considerations into upstream development and design, right? So maybe there's a change you make in how you publish information, or maybe even a certain design change, right, to prevent a specific unintended use. And finally, your work is not necessarily done once you have a product out there, as unintended consequences can occur at any stage. So it's important to monitor the space and really pay attention to unintended uses and use cases. So the takeaway from this section is really the three main points on this slide: to engage in proactive anticipation, reflection, and monitoring with regard to unintended consequences of neural devices. So what are the main points I'd like you to take away from this lecture? First, there are many emerging ethical issues in neural device research for which there is little consensus or industry-wide standards. And funding bodies like the NIH are signaling that you should be aware of these issues and should be engaging with them on your proposals and in thinking about the translation of your product. And here we focused on three issues: informed consent, post-trial responsibilities, and unintended consequences. Next, in the absence of any kind of formal guidance, it's important to consider the most ethical pathway forward given the current knowledge of ethical issues and emerging ethical issues in particular. And there are bodies of literature here, often in the ethics and neuroethics literature, where people are writing and thinking about these issues. So searching for those articles can be quite useful. And as you've likely gathered by now, The overarching themes are the importance of anticipating future scenarios, reflecting on them and acting accordingly, such as planning ahead and disclosing future scenarios to research participants. So there's a lot of further reading here, but I wanted to direct you to the Hendricks et al. Paper in particular. It's a great paper that I think really does the best job of covering the main issues. And there are great tables with specific points to consider for informed consent, how to think about risk outside of safety, as well as post-trial responsibilities. And if you want to dig deeper on any of the 3 topics that we've covered here today, I've included additional citations. And here's a list of additional resources. So the first is a link to an RCR training course. The second is a link to additional RCR resources. The MCAT CR, which I mentioned on an earlier slide, is a formal tool used to assess capacity to consent to research. And I've included 2 links here to responsible innovation toolkits, though there are many more that are being developed. So thank you for taking this course. I hope it's been useful, and I hope it's helped you think through some of the ethical issues that you'll encounter when translating neural medical devices. Thanks.